the diagnostic approach to polyuria and polydipsia. I think this is the one most common clinical sign that we can find in daily work. Okay, and when we see or when we can confirm that the patient presents polydipsia, when the dog is consuming or drinking more than 19 to 100 milliliters per kilogram a day, and a cat is drinking more than 50 milliliters per kilogram a day. What is important to consider polyuria polydipsia, what kind of type of diet is eating the dog or the cat, because probably if a dog or cat is eating a dry diet, drink more, no? And if it's eating a wet diet, drink low, okay? The most common cause is when produce a polyuria. This polyuria produces a compensatory polydipsia, okay? Another physiological causes that can produce this polyuria, polydipsia, is exercise or ambient heat, mainly in summer. Let's talk about just a little bit about the pathophysiology of water metabolism. If you see here, all this structure and mechanism is implicated between interaction, control of the water consumption and the urine production, mainly the kidney, the third center, pituitary gland, and hypothalamus. Okay? And it's very important to consider the osmolality or plasmatic osmolality. We have to remind that sometimes the urine need to have an increased osmolality in comparison with the plasmatic osmolality. We know that this plasmatic osmolality depends on mainly of the concentration of sodium. For that reason, the sodium is so important to control the polyuria and the polydipsia. And mainly, this concentration of sodium allows to the body to do different adjustment the total the concentration of the total body water. And there is a control or stabilization between the water balance, and this stabilization or balance is achieved between the water intake and water loss. Where we can pass the body, we can lose water, mainly through the urine, through the feces, and when we are a dog panting, okay, or with respiration, or through the skin, okay. But that is not so important like a urine and the feces. What's happened when we lose water? Activate the ADH, okay, and this antidiuretic hormone produce that urine concentrate, okay, and at the same time active another mechanism to increase the water intake through the activating the third mechanism, mainly the third center, okay? And this is how acts the antidiuretic hormone called ADH, or another name that we can find in the text is adenine vasopressin, that is ABPA. This is a non-peptide, and this hormone controls the water absorption, mainly the kidney. This is the way that works. We have to remember that the ABP is produced in the hypothalamus and is stored in the pituitary gland, mainly in the posterior pituitary gland, okay? And it's stored over there. And when something happens in the body, mainly a decrease the circulating plasma volume, is activated the atrium, the veins, and carotid sinus, to stimulate the production or release of AVP that is stored in the pituitary gland. Okay, this AVP exert a stimulation of the kidney, mainly in the distal tubules and the collecting tubules. Okay, and this produce that interact with B2 receptor, and these B2 receptor facilitate that insertion of water channel called aquaporin 2. Why we need this water channel? That there is a movement from the lumen of the tubule to the interstitium easily, okay, like a gradient, okay, and in this way is the AVP produced that a response of the kidney, okay. Later, how maintenance of the osmotic gradient depend the counter-current multiple system that we can find here that increase the osmolality in the loop of Henle, but later decreased again. But here is where we find a higher osmolality gradient in the tissue of the cell, of the kidney, sorry. What is essential diagnostic test in a patient with polyuria polydipsia? CBC, complete biochemistry. In CAT, measure total T4 and TCH. Right now we are measuring the TCH in CAT. Urine analysis. When I see a dog or cat with polyuria polydipsia, my recommendation is to do a cure of USG, okay? Because sometimes for stress, for change of diet or something, can increase the drinking of water and decrease in just in one moment decrease the UCG. For that reason, my recommendation is that the owner brings you urine from the morning, from the evening, and from the night. Okay, and you do a cure of urinary specificity. Okay, because in some time during the day, this dog or cat can concentrate or not, and that helps you for the differential diagnosis. And another recommendation is to do urine culture and sensitivity and measuring of the systolic blood pressure in this patient. Okay, if you see this formula, I think we are use this formula in cats with hyperosmolality diabetes. Okay, but have been proved that this there is not a good correlation between this formula with the real osmolality. So the gold standard is to have a machine to measure the osmolality, but I have never used one of this machine. Okay, how we could call the urine according to the number that obtained in your urinary specific gravity. This is the correct number. In dogs over 1.30, we have to, in cat 1.35, we have to call correctly concentrated, okay? Between 12 and 30, we have to call moderate concentrated, and between 8 and 12, that is isostenuria, that's the plasma osmolality is the same that urine osmolality. And low to 1.8 is when we call hypostenuria, okay? And this phenomenon mainly we use for the Addison, okay? When a dog comes totally dehydrated with the additional crisis, and you do a urinalysis and you find it incorrectly diluted, okay? There is not a good physiological mechanism to respond to the shock. This is you can find this algorithm in the last version of edition of the Ettinger, and mainly that's what we're going to talk about. But when we have a patient with Polyuria polydipsia, we have to check, or the first time we have to check is the USG. Okay? But it's very important to check the presence of glucose. Okay? You have to remember that glucose has a higher osmotic capacity and can increase the USG in the patient is a false increase. Okay? And if you don't find the glycosuria, you have to all these causes to try to rule out, and we're not talking about a little bit. And all the time is very important, consider if this patient is receiving any kind of treatment. You see here a list of different medications that can produce you Polyuria polydipsia, and that we have to ask to the owner if the patient is receiving any kind of treatment. Okay, that's with asterisks are the more common. And for example, phenobarbital sometimes forgets that can produce Polyuria polydipsia. Okay, mainly you have to think something happening in the liver for the phenobarbital, or even thicortal for the treatment of the Addison. When you are using a higher dose, can induce iatrogenically and Polyuria polydipsia in a patient with Addison that is not controlled. Okay, and this is a table you can find. This is a memory for me and try to teach to my resident. When we see a dog with hypothermic urine, mainly we have to move in this differential diagnosis. Okay, we're going to talk about different types of Polyuria polydipsia. One of them is osmotic diuresis. The pathophysiology is mainly is increase the number or concentration of solute in the tubular filtrate, and that solute attract water, and for that reason increase the water excretion from the kidney. Okay, and this produce a polyuria, and secondary produce a compensatory polydipsia. Okay, what causes, or which causes are more common of osmotic diuresis? The more common, diabetes, mellitus. Okay, I forgot to put it mellitus. Okay, CKD, post-obstructive diuresis that I'm talking just a little bit in the first talk. Medications, diuretic, mainly furosemide, mannitol, and the fluid. You can induce the polyuria, osmotic polyuria, because remember, this is salt. Okay, and another kind of glucosuria, more frequent, primary renal glucosuria or Fanconi syndrome. What we can find in diabetic, we can find normal concentration of the urine, but it's false, remember, because the glucose has a high weight. Okay, hyperglycemia, glucosuria, and produce the osmotic diuresis. And the renal threshold for dogs is lower in comparison to cat. And you have to remember that some cats, for stress, can increase the level of glucose or glycemia over 300. Okay, so we have to differentiate all the time in cat that this glycosuria, hyperglycemia is induced by stress, or induced that this cat present a really diabetes mellitus. Okay, and the renal glycosuria, primary renal glycosuria, is a very uncommon disease, and you can find a normal glycemia. Okay, in the normal glycemia, but you find glucosuria. Okay, do you have, or how many cases of leptospirosis you have here in Romania? Is frequent or not? Really? Okay, and Babesia? Okay. I was thinking any kind of infectious disease you have to have. Okay, Babesia. I love Babesia. It's very weird in Spain. And sometimes can be, or you can find secondary glucosuria. Okay, and is normal, the glucose in the blood, but in the urine you can find glucose, and you have to think mainly that secondary renal glucosuria is more common than primary glucosuria, and one of the case is a patient with CKD, leptospirosis, and leishmaniosis. Okay, and sometimes the babesiosis can be a damage only in the tubule before the glomerulus and induce you as well glycosuria. Okay, how the CKD can induce you a polyuria polydipsia? There is a different mechanism, but this is the main mechanism. But here, more the patient, or it's very common to find a patient that is isostenouric urine, and that I said before, the osmolality of the urine is the same of the plasma, okay, and that produce an osmotic polyuria, okay, and what we can check in the blood work, we can check to CBC, obviously biochemistry, the creatinine, urea, and SDMA. You used to use the SDMA, okay, yes, phosphorus and calcium, abdominal ultrasound, and I do all the time urine analysis with urine culture and sensitivity, and don't forget, measure all the time the blood pressure in this patient. What's happened in the patient with CKD? The nephron that's maintained in the leaf in the kidney increase or try to increase the compensatory glomerular filtration and increase the distal tubular flow rates in the kidney. That means that the urine is passing away very quick, and that is not allowed, or there is not so much time to reabsorb the urea to the interstitium. So the cat or the dog is peeing urea, and urea has a huge osmotic capacity, so attract water, okay? And at the same time, the urea is very important to maintain the medullary concentration gradient, and if you don't have urea, that gradient is lost. So again, the gradient or the passive gradient, the loss of molality and hydromolality doesn't happen for this reason, and the dog and cat peeing a lot. Okay, and that is one of the explications, but the main explanation for why a patient with CKD present polyuria polydipsia. The post-obstructive diuresis that I'm talking just a little bit, what's happened? That increased the elimination again the urea, because the concentration in the blood of urea is so high that again the compensatory mechanism to try to reabsorb all that urea that is present in a blocked cut is not enough, and for that reason is peeing urea, okay? And again, this urea attracts water and produce a post-obstructive diuresis. What's happened? That this diuresis can long 7 days, 10 days. So before, one of the recommendations in that cat with fluid is no send home till you control the polyuria. But if you give a cat so much fluid, urine so much fluid. So when I see this post-obstructive diuresis more than 3 days, mainly for another cause, not cystitis, I try to decrease the rate of fluid to try to correct for myself, well, for the cat itself, correct this compensative or post-obstructive diuresis. Another mechanism is the acquired nephrogenic diabetes. This one, we know that distal tubule and collective ducts are unable to respond to ADP. Okay, this happens. The most common cause is secondary. Okay, this one is more real, the primary or congenital nephrogenic diabetes insipidus. Here there is there are reduced response to AVP in the distal tubule and collected duct, mainly because the receptors are blocked. There is an interference for to attach the AVP to the receptor. And we have to remember that AVP is produced that the aquaporin channel appear in the tubule. Okay? So if I don't have AVP, I don't have aquaporin channel. Okay? And another way, the kidney are enabled to maintain the osmotic gradient between the tubular fluid and medullary interstitium, and in this way is lost the medullary hypertonicity, similar to the happening in the osmotic diuresis. Well, which are the causes of secondary nephrogenic diabetes insipidus? Mainly endotoxins, hypercalcemia, hyperadrenocorticism that produce a reduced response to the IVP. And another cause is lost osmotic gradient, is hypoadrenocorticism, liver failure, hypokalemia, CKD again, but we're going to explain this one again, and diuretic drugs, maybe. Sorry. Why a pyometra present polyuria polydipsia? Okay, we have here the answer. If someone of you is making these questions, okay, and mainly is the Escherichia coli. The Escherichia coli is the main cause. These have endotoxin that has able to block the receptor, okay, the AVP receptor, and it is this way that produce the polyuria. So this is acquired nephrogenic diabetes mellitus, okay, and everybody knows it's more common in all the entire females. That the estro was present 3 weeks or 4 weeks before or 2 months before, can be open and closed, and all the tests that you can do in pyometra. Pyelonephritis, and again, depends on the kind of bacteria that is infected, that this bacteria is, for example, again, Escherichia coli can block the receptor, but another bacteria can produce endotoxin and as well produce this AVP action not able in the tubule to produce the aquaporin channel, and at the same time can produce the infection of countercurrent mechanism or affect the countercurrent mechanism. That's the water with low osmolality go to a place with high osmolality is affected as well. In these cases, one of to obtain the diagnosis, the most common test that we do is cystocentesis. But what of you do pilocentesis? Okay, it's not common. Just I mean, my experience is some patient I have done when I see a dilated pelvis and I don't find the cause in the blood. I mean, the culture in the blood is negative or not grow anything. So it's when I do the pilocentesis because it has more risk than cystocentesis, like bleeding. Okay. Hypercalcemia. Hypercalcememia, again, the calcium interfere with the AVP receptor in the tubules, and the calcium itself can damage the receptor and block and damage the receptor. So at the same time decrease the transportation of the sodium and chloride to the medullary interstitium. So in all this way is affecting mainly for the destruction of the AVP on the osmotic diuresis, and can produce the polyuria polydipsia. For this reason, patients with primary or secondary hypercalcemia can present polyuria polydipsia. Okay. For All the time, one of the recommendations is measure the ionic calcium. Even I measure in patients that have total calcium over the upper limit, okay, on the range, okay, in the reference range, in the upper limit. I measure the ionic calcium in patients with Polydipsia, because there is not good correlation between calcium, total calcium. You have to remember that the calcium can be joined into proteins and albumin, carbonate, and the ionic. And what is the better to measure or can produce you? The problem is the ionic, okay? And for that you need a special machine, but you can have this machine in your clinic or your hospital. When I see a dog or cat with hypercalcemia, here's a table with all differential diagnoses, since the most common to the most rare or miscellaneous causes. And we see a patient with hypercalcemia, we have to think in different tumors like lymphoma, anal adenocarcinoma, pancreatic adenocarcinoma, etc., CKD, and Gesternulobacterium. You have this kind of parasite here in Romania? No? Okay. Addison disease, don't forget the Addison can produce hypercalcemia and idiopathic in cat, but in cat you have to rule out all the causes of hypercalcemia to confirm the idiopathic hypercalcemia. Yes, and this is picture from where I'm working with. We diagnose fungal disease. The granulomatous disease can produce as well hypercalcemia. Hyperadrenocorticism. What is one of the most common cause of Polyuria polydipsia, and how this is produced? The cause is not clear right now, but there is thinking that the glucocorticoid exerts a direct interference over the ABP receptor for, in this way, produce and acquire nephrogenic diabetes insipidus, but at the same time, the cortisol can affect the production or the storage of ABP in the brain, and there is less quantity or amount of ABP present to go to try to join to the receptor, okay? And another hypothesis is that there is a direct effect of the cortisol over the glomerular filtration rate increasing, okay? More than 85% of dogs with USG low than 1.20, and the urine is moderately concentrated to hypostenuric urine, okay? How can produce this? Mainly is when a compression of the pituitary tumor. We have to remind that the most common causes are microadenoma, but macroadenoma. This macroadenoma can compress the posterior pituitary and produce. And this is a picture of patient of mine with Polyuria polydipsia, and this is a macroadenoma. And maybe for the diagnosis, we choose the cortisol creatinine ratio when I don't have so much suspect, or this is low in my list of differential diagnoses. But what test do you prefer to do in dogs with hyperadrenocorticism? Grab your hand with low dose dexamethasone stimulation test. 2, 3, 4, 5, 6, okay? And the ACTH stimulation test? Yes. Everybody? Yes. Okay, broad answer. Why? What's happened? The sensitivity of the ACTH stimulation test is only of 70%, 75% sensitivity, okay? The specificity is very good. So, What's happened when we use the low dose dexamethasone suppression test? Sorry. The sensitivity is between 90% till 100%. Okay? But specificity could be very high if you use in an adequate patient. Okay? If you use this test in a patient that don't have all the typical clinical signs of Cushing, can give you a false positive. Okay? So if you have to choose all the clinical signs of the dog, the better test is this one because the specificity is over 90% as well. Okay? When I use the stimulation test, when the low dose dexamethasone suppression test is not clear, or if very important to do the test in a sick dog, okay? Because in a sick dog, if you do the low dexamethasone low dose dexamethasone suppression test, could be give you false positive. In a sick animal, I use the stimulation test. Okay. And another cause is the liver failure. The liver failure, and again, decrease the concentration of urea in the blood, and this allow a loss of medullary hypertonicity, and in this way produce and acquire nephrogenic diabetes insipidus. At the same time, the ammonium exerts effects over the hypothalamus and mainly another substance. You have to remind that we have the portosystemic it's not only the ammonium that can produce the hepatic encephalopathy. There is another amino substance like a benzoyl diazepine and something, a lot of another substance. And this substance acts like a toxin and produce or affect the hypothalamus and produce the polydipsia. Okay? What kind of test you have to do in this patient with liver? Mainly the dynamic bile acid test and measure the ammonia. If you can measure in your clinic or hospital. And in mainly cat with you suspect the cholangitis. We obtain mainly bile cytology and liver cytology and culture of the bile. Okay, and in patients with liver disease dogs mainly and some cats, I prefer to do the histopathology measuring the copper and do a mix of bile with tissue to send to culture and sensitivity. Hypoallergenocorticism helps produce polydipsia, and again, 30% of dogs with Addison present hypercalcemia. And another way, dogs present a higher concentration of potassium hyperkalemia and present a compensatory hyponatremia. And hyponatremia produces a loss of osmotic gradients, mainly the renal medullary tonicity. And for that reason, the urine is more diluted. Okay? And the polyuria is presented in 20% of dogs with Addison, and mainly you have to be attentive to see the sodium potassium ratio, mainly less than 27, okay, or even more better correlation, less 23, and to do the ACTH stimulation test, okay. Another cause is hypokalemia. Hypokalemia, mainly in cats, is secondary to renal disease. Okay, and again, it produces a low response for part of the tubule to the ADH and decrease the number of aquaporin 2 and then disappear the channel of water and interfere the ADH secretion in the pituitary directly the level of potassium. But okay, it's central brain. And polyuria in patients with hypokalemia, exclusive hypokalemia, for example, secondary lipidosis, is not common to find polydipsia, but in Burmese cat that is not very frequent breed in Spain, is more frequent to find it in UK, can present hypermaric hypokalemia and present polyuria polydipsia. And hyperthyroidism. The pathophysiology of the hyperthyroidism is not clear currently, and increase the renal flow and decrease the renal medullary tonicity and decrease the water reception, and for this reason produce the polyuria. But there is a stimulus of the brain is stimulated directly for the T4 and produce a psychogenic polydipsia, okay, a primary polydipsia. Or even we have to remind that this cat leak a lot, or even take out the hair, because they feel so much warmth in the body, and this warmth can produce loss of water. Okay. We're going to talk a little bit about the diabetes insipidus. Do you know why it's called insipidus? Okay, this is very clear because in the old time, the doctor to difference between mellitus and insipidus taste the urine, and when it's mellitus, the glucose is sweet, and this kind of diabetes doesn't have any kind of taste. And for this reason, it's called insipidus. Okay, it's a little bit gross, but okay. And here we know that there is a clear vasopressin deficiency, mainly the affecting that interaction between ABP and the distal tubular and the collecting duct cells, and again decrease for this reason the aquaporin tune and the channel of water. And the water is not reabsorbed in the ductal tubular and the collecting ductal, distal tubular, can produce at the same time not induce that the sodium and chloride goes into the interstitium. For that reason, there is a hypotonic tubular fluid, and at the same time occur a hypotonic urine. All of these produce an increased water intake due to increased osmolality in the blood. Causes of central diabetes insipidus can be mainly when it's affected the hypothalamus or posterior pituitary. Remember that is where produced and stored the ADP. Could be idiopathic in young patient, and neoplasia that affected the hypothalamus or pituitary gland in old patient, metastasis, cyst and lymphocytic hypophysitis that is very uncommon in dogs. Another cause are trauma, mainly in cats with a skull fracture, vascular accident, or the surgery that you can do in UK or in Netherlands, that, as a treatment for the Cushing disease and for the acromegaly, that take out the pituitary gland. And all this produce a marked polyuria with the compensatory polydipsia, could be acute or progressive, could be associated with neurological sign, and the diagnosis is for exclusion, okay? And this patient tends to present hypernatremia. Okay, when we exclude all the causes of the central diabetes, we are thinking that we are from cases of central diabetes insipidus or nephrogenic diabetes insipidus, primary, okay? Or psychogenic polydipsia, we can propose to do the test that everybody knows called water deprivation test. How many of you would you like to do this test? Or have experience with this test? Nobody? Okay, good. I like that because this is a test that I don't like so much, but we're going to explain you just a little bit, okay? This test we have to, when we suspect in these 3 diseases, we have to do that USG curve that I mentioned before. I prefer that the owner bring me from home the urine. And when the patient presents hypostenuria, I am thinking about that I do the desmopressin trial test, or I do the modified water deprivation test. We want to talk about that. Prior to the water deprivation test, this is called modified because we have to decrease the medullary washout, because most the patient has a long time drinking a lot of water and peeing a lot. So this produces a consequence called medullary washout. To decrease this medullary washout that sometimes not allow to concentrate the urine only for medullary washout, we have to decrease slowly the amount of water that the patient is drinking. Okay, it's important when you start to decrease this restriction of water. Start only with 10% every 1 or 2 days. Okay, until the patient, mainly dogs, is drinking 100 milliliters/kilogram per day. Okay, different offering water in different time a day, and you have to monitoring the weight and USG, sodium, and the patient attitude. Okay, and for that reason, I ask to the owner bring to me every day or every 2 days. Okay, if the patient presents increase of the USG with the restriction of water, we stop the proof and we now go to the second step. Or if the patient presents azotemia, we cannot to do the deprivation, water deprivation test. Okay. When come the dog to do the deprivation test, we have to come fasting, minimum for 12 hours. Okay. The clinical sign dehydration or azotemia. We hospitalize to the patient in the morning and put it in catheter to empty all the bladder and start to measure the production and USG. And if you can have measure the urine osmolality, that I don't have experience with that. And we have to measure every 2 hours levels of creatinine, sodium, okay, and the clinical sign. If the patient presents dehydration, lost weight, but because probably is dehydrated too much, and levels the creatinine and sodium is increasing already. Why we have to measure this? Because if the patient, when they start the water deprivation test, you are not allowed to the dog drinking anything, okay? And if the patient presents azotemia or hypernatremia, depression, apathy, behavior changes, obnubilation, weight loss, or increase the dehydration more than 5%, you have to stop the test because it's very dangerous for the dog, okay? Because remember, it's increased suddenly the level of sodium can dehydrate the neurons and produce and brain damage for forever, and even can die the patient, start to seizuring and die. So for that reason, it's important to measure every 2 hours, and for that reason, it's a test that I don't like so much. What happens if the patient resists the water deprivation and the dehydration is less than 5%? Is in that moment when I apply the drop of desmopressin, okay, desmopressin acetate. In that way, again, empty urine collecting back, measure the use and the urine, and measure creatinine sodium in the patient. And after you finish the test, you have to replace that fluid that had lost in the hydration. This patient may in 2 hours. It monitor very close to the patient for 4 hours more, and after the rehydrate to the patient is when you can offer water and leave it to. And how we can translate the result mainly. When I see a patient with diabetes insipidus, more of the patients achieve less than 5% of the hydration at 4 hours, and you apply the drug and you see an increase quickly of the concentration of the urinary specific gravity. Instead of, if you see, although if you see the primary nephrogenic diabetic insipidus, you have to remember this patient doesn't have receptor for the ABP. So if I put synthetic ABP, doesn't work and doesn't happen. So the urinary specific is still hypothermic in all the tests. And for another way, on the other hand, the primary polydipsia can present a mild response to the when you apply the drop, but most of them, when you do the gradual restriction of water, you see an improve of the urinary specific density, even when it's achieving the 7%. What's happened in this dog with primary polydipsia? The test can be too long, too long. Some dogs can be aggressive when you take out the water. And this is the protocol that I prefer, and it's not danger for the patient, is to apply the drops. I prefer the drop and the tablet because I have seen in some studies that are more effective in comparison to that tablet. Tablet I prefer to use in cat because the drop can produce conjunctivitis and be little noisy for cat and some from dogs. Okay, and when I do the test, usually I use 2 drops. Okay, and you have to measure it, the USG every 24 hours during 5 to 7 days. I prefer 7 days because some dogs delay to respond. Okay, how could see or read the result, or how to know that the patient is responds to the vasopressin? There is a marked decrease on water intake in days 5 to 7 in comparison with day 1. Increase the urinary specific gravity may increase 50% more than the baseline. Okay, not all the patients you can go into the normal limit. Okay, that is important to remind. And you have to remind that congenital nephrogenic diabetes insipidus doesn't respond to the synthetic vasopressin, but you can find a small response with patient with Cushing, and sometimes very difficult to differentiate between primary or central diabetic insipidus with Cushing. For that reason, it's more important to do all the tests for rule out the Cushing echography we talked about before. And psychogenic polydipsia has a partial response as well. Okay. When we have a treatment with central diabetes insipidus, we have to try achieve the minimal effective doses with the tablet or with the drop, okay? And the injection vasopressin is not available right now in Europe. And in some patients, you can use propamide you have to remind this is a treatment for the diabetes mellitus in human beings, and this increased the ADH stimulation in the renal medulla and remove antagonists and increase the sodium chloride absorption in the renal medulla. Okay, but in veterinary it's not good result in the study, but it's another option. Regarding congenital nephrogenic diabetes insipidus, mainly it's very weird. There is only this article published many years ago in a family of Siberian Husky. So this is disease that you have to consider in Siberian Husky. Mainly, you can try to use the water deprivation test again that we talking about and rule out all the causes of nephrogenic diabetes insipidus. And the treatment is acid diuretic, mainly is the chlorothiazide, and this one is a paroxysmal effect that increase the elimination of sodium in the urine, and in this way the total body concentration of sodium decreased and reactive all the mechanism compensatory to try to absorb the more quantity of water in the ductal tubules. And that's it, and thank you very much.